Thank you, and certainly a pleasure to share our experiences and clinical data for this particular procedure. But I do want to thank the previous two speakers for kind of giving examples of the way that our field is trending towards evidence-based medicine. Certainly, it's interesting to understand the dynamics of radiofrequency ablation and how that was applied to the cardiac space, and maybe how our field is kind of catching up in terms of differentiating some of those types using evidence. It also highlights to me the interplay between our specialty and how we're really able to work with other disciplines in different ways today because of these different tools that we have in our toolbox. So Ajay described the interplay for knee osteoarthritis with radiofrequency ablation, and certainly excited to discuss our role in treating patients with symptomatic lumbar spinal stenosis with a safe and effective procedure, the mild procedure, or percutaneous image-guided lumbar decompression. Certainly the procedure itself, many of us in the room are familiar with it, using several tools with a percutaneous approach to debulk the ligamentum flavum. It's a procedure that's been around for quite some time, but has actually seen an evolution both in its utilization, how the procedure is done, and also perhaps where it falls in our treatment algorithm. And I think that's probably the most important point to discuss today in terms of how the procedure is integrated into our practice. I think previously some of the procedures that we've had in our toolbox have been somewhat last resort options. We look at spinal stimulation, we look at these procedures for lumbar spinal stenosis, and I think that some of us, including myself, have fallen into patterns of practice where we're kind of doing the same thing for patients with limited efficacy and maybe only thinking of these other options as a last resort tool. I would challenge everyone here to kind of think outside the box a little bit in terms of lumbar spinal stenosis, and I think Dr. Mehta did an excellent job of introducing that concept when he discussed indirect decompression. When we talk about direct decompression here with the mild procedure, we're really talking about a safe and effective procedure that can be done for our patients with symptomatic LSS and associated ligamentum flavum hypertrophy. I feel very strongly about this procedure in terms of not only utilizing it in my practice in addition to the other tools for lumbar spinal stenosis, but I think it's worth us revisiting patient identification. And I will tell you from my own experience and sharing my experiences with colleagues throughout the country, that patient identification and asking the right questions for symptomatic lumbar spinal stenosis has probably been the key for me to be able to correctly identify the problem in our practices and then also be able to discuss treatment options with a particular patient. I think my experience and my training in medical school and fellowship about lumbar spinal stenosis was a little bit flawed. I understood that this was a condition predominantly treated by neurosurgeons. I understood that our role as interventional pain physicians was really to provide injection therapy, and that was really the end of the line. I also know that when I was described lumbar spinal stenosis, I always thought of it as a bilateral condition. I always thought of it having to have more significant leg symptoms than back symptoms, and I think our understanding of that has really changed. We heard about different zones of the spinal canal and different presentations of symptomatic lumbar spinal stenosis earlier. And we also know that many of these patients, don't complain of predominantly leg pain, but they actually complain of back and buttock pain that can be easily missed in a clinical setting. I think many patients who present to my office with, symptomatic LSS actually do complain of back pain, and it's up to us to ask the right questions in terms of, is this a claudicatory picture in terms of worsening symptoms with extension and relief in some sort of flexion? I will kind of harp on that a little bit more in the fact that many of the times when my medical assistants are asking the questions in terms of teasing out LSS, they will ask the patient, does it bother you when you stand and does it get better when you sit down? Well, that simple line of questioning may not be enough. Many of our patients have trouble with prolonged sitting, and if we're not able to tease out the mechanisms of worsening symptoms in any form of extension, including standing upright, lying flat in the supine position, and some relief with any form of flexion, meaning sitting in a chair, meaning tucking your knees into your chest, or of course the shopping cart sign, which we're all familiar with. But asking those right questions in a directed and efficient manner has really changed my practice and allowed me to be able to identify more patients and treat them with a definitive therapy like mild. We certainly use a team-based approach, and so this is what I would also put in a plug for really involving all members of the team to identify these patients correctly. And really it's a team effort. It starts with when the patient walks in the door. Those with a cane or a walker immediately are eyes are raised, and cues are there for symptomatic LSS, and then simply asking the right questions in that efficient manner has really allowed us to put patients on the proper treatment pathway, and in our practice actually evolved into this algorithmic care model where we're able to discuss advanced options with the patient really at their first visit and come up with kind of a plan A, B, and C in terms of their care. What that has allowed us to do is really move to more definitive treatment options faster, and often paired these options, which are really, such as mild as a percutaneous, minimally invasive procedure with minimal recovery time, paired it against a repeat epidural steroid injection, which may in the past have provided very limited efficacy. I think when we talk about epidural steroid injections, we'll get into it a little bit later here, but certainly we all see a role for them and certainly have big portions of that in our practice. But the repeat epidural steroid injection for a patient with chronic long-standing lumbar spinal stenosis, we all know has limited efficacy, and it's worthwhile for us to discuss other options with the patient earlier in that process so that we can come to more shared decision-making that can ultimately lead to more durable outcomes. When we talk about patients with comorbidities, these are where the interplay between a spine surgeon and some of our options that we have as interventional pain physicians come into play. And so types of spinal stenosis can be variable and the cause can be variable. And we know that decompressing a few millimeters of the ligamentum flavum can increase the diameter of the spinal canal regardless of what the type of stenosis is. And so many of the patients that have been treated with mild have these comorbid stenosis causes but still provide these durable outcomes. When we talk about also existing risk factors, some of them can be a little bit problematic for some of our procedures for lumbar spinal stenosis, and that can include multiple levels, that can include pre-existing hardware, that can include the inability to tolerate surgery. And so many of us in our practices, when we first kind of started with this procedure or other options for spinal stenosis, we kind of have to work with surgeons to decide, okay, which patients are not good candidates for surgery. And those are such low-hanging fruit because these are the patients with sometimes advanced disease, perhaps sometimes severe stenosis, that really have no other options. And so these patients are ones that exist in our practice that we certainly have the ability to help. And so when we talk about the procedure itself, again, we are talking about pairing this procedure as potentially the next step after an epidural steroid injection does not provide durable relief. Now, we're not talking at all about the patient who presents with acute radiculopathy type symptoms. We're not talking about that disc herniation. We're talking about chronic, long-standing lumbar spinal stenosis in which the patient getting repeat epidural steroid injections may be really riding this roller coaster of relief and then waning relief and waiting for that next injection that does not necessarily produce that functional improvement that really is desired for patients with lumbar spinal stenosis. Again, the ability to treat lumbar spinal stenosis with a more definitive therapy than just an epidural steroid injection often attracts a particular type of patient to our practice relative to other options if we are in a competitive environment, and actually offers us the ability to differentiate ourselves. And this type of patient with lumbar spinal stenosis is one that wants to get up and walk. This is a functional disease, a very common problem in our population, especially our aging population. And if we're able to offer another solution, potentially besides an epidural steroid injection, it gives us more of a thought process for our patients that, hey, we know what another option could be for you if this injection doesn't work. And so in my practice, we've certainly had that conversation sooner than later. And everyone in our practice, including my PA and the rest of the staff, is able to discuss with the patient, hey, we all are kind of on the same page about what's plan B after that epidural steroid injection doesn't work. We do have some data regarding the repeat utilization of epidural steroid injections for chronic and long-standing lumbar spinal stenosis. This is a paper from Friedley, and we do see that if there was no short-term benefit in the first 6 weeks, repeated injections did not provide long-term benefit. And so this is data that kind of interplays with the next set of data that I will share in terms of this robust evidence for the mild procedure. The mild procedure has a very growing and effective body of evidence that has not only level 1 studies, but real world and registry data that shows continued and consistent efficacy. And these are a group of kind of leading physicians across the country who not only have evolved the algorithm in terms of LSS to pair it as the next step after an epidural steroid injection, or even propose to offer it instead of an epidural steroid injection, and we've really seen no difference in outcome. And so these are some of our thought leaders that have really paved the way to change the algorithm for lumbar spinal stenosis and be able to offer this definitive therapy earlier in the algorithm. And I do believe that at least discussing that with the patient is best for patient care. You can see in this slide here that, that multiple ESIs versus no ESIs or a single injection really showed no difference in outcome with this particular procedure. And that is a talking point that I think is worthwhile having that discussion with the patient after the confirmation of a diagnosis of LSS. And then we engage in this shared decision-making process with patients about their options and about potential evidence and our own clinical experience with those options. And that's how we ultimately lead to the best decisions for our patients. Long-term data is certainly robust with the mild procedure. We have level 1 data to show efficacy in hundreds of patients, 2 level 1 RCTs, Midas Encore data. This was, the studies were very instrumental in allowing this procedure to come back into our hands. But we've actually seen durability data. We've seen 5-year data produced by Dr. McHale at the Cleveland Clinic to show that nearly 90% of patients over a 5-year period that had the mild procedure did not go on to open surgical decompression. And so think about alleviating the need for that larger procedure for this huge percentage of patients is very effective and telling. We've also seen, functional improvement, meaningful reductions in ODI, and most importantly, in my mind, a safety profile that is robust and really equivalent to an epidural steroid injection. There have been some procedural modifications to the technique that are also worth noting. We've seen safety and efficacy data that actually questions the need for an epidurogram, and so some of the endpoint maybe problems that arose with our early experience with this therapy in terms of longer procedural times, higher fluoroscopic times, and then also the epidurogram at a stenotic level has actually been questioned by some of our leading physicians, and our goal is really to establish the same efficacy with streamlining the procedure and making it safer for our patients. We do have functional metrics that show the improvement in standing and walking time. That's really the goal of treating lumbar spinal stenosis. And so I would challenge all of us to do a couple things in terms of this entity in our practice. One is certainly look at lumbar spinal stenosis with a more critical eye. Familiarize not only ourselves but our staff with asking the right questions in order to tease out the diagnosis of lumbar spinal stenosis. And then really look at maybe what we're doing for our patients in terms of definitive therapies. And those patients who have been riding that roller coaster of waxing and waning relief with repeat epidural steroid injections, is it perhaps reasonable to offer another option? And in our practice, when we see a patient for a first-time visit with lumbar spinal stenosis and we're able to confirm that with advanced imaging like an epidural steroid injection, we have kind of a common practice in our location to discuss all options available to the patient and then engage in that shared decision-making process. Again, the safety profile for this procedure, equivalent to the epidural steroid injection. The intent of all the instrumentation is to remain outside the spinal canal and posterior to the ligamentum flavum, and that offers the highest safety profile of this procedure compared to even other procedures that we commonly do, such as spinal cord stimulation, or even, one could argue, the epidural steroid injection itself, because that needle does penetrate the ligamentum flavum into the epidural space. And so in summary, the mild procedure or percutaneous image-guided lumbar decompression, certainly a very effective tool in the toolbox in my practice. I think it's on us as interventional pain physicians and our community to arm ourselves with the best tools possible. What we want to do is produce effective results for our patients, of course, but with the highest priority on safety. And some patients who an implant is not suitable for, this is certainly going to be their treatment of choice. And so patients with lumbar spinal stenosis are in our practice. We work with other colleagues around different disciplines that may be involved in the treatment of these patients as well. And it certainly offers us the opportunity to maybe have advanced level discussions with those different disciplines and those colleagues to really make this multidisciplinary approach for our patients. And then certainly these patients with lumbar spinal stenosis on the epidural roller coaster, I'll call it, certainly may have a better option for us here. In closing, I definitely want to thank ACIP for this meeting, and thanks to the leadership of ACIP for certainly organizing this and having this forum here today.
We're actually still a little ahead, so my saluting continues, Ajay. Thank you. If Dr. Maid's here, I'd love him to get up and answer this question as well. Let's say you had a patient that was equally good for potentially doing a spacer or mild, understanding that in many situations it's not equally, but in this hypothetical, would you do the spacer first or would you do mild first?
Yep, so that's a very common clinical scenario that will come up in practice, and many times there are comorbidities or image findings that sometimes lead us to the right decision where one may be contraindicated versus another. But if they are equal, what I would do is I'd have this shared decision-making process that occurs with the patient, perhaps explain the pros and cons of each, and I'd also share the clinical data regarding those. And then, we do have guidelines that say, kind of missed guidelines kind of indicate that potentially moving to the direct decompression with this procedure may be favorable because you can still intervene with an interspinous spacer afterwards. And so that's a process that I would just discuss with the patient and allow them to participate in that decision-making process. But overall, these are two great therapies. Again, I wouldn't necessarily kind of advocate for the argument or the conversation spacer or mild. I think we need to switch the conversation to advanced intervention for spinal stenosis versus the repeat epidural steroid injection.